Dear colleagues, dear all, welcome to this new ACVI webinar recorded from the studio in Nice. I'm Bernard Cousins, I'm a cardiologist working in a university hospital in Brussels, Belgium, and I'm delighted to learn that we have a lot of connection for this webinar, but it's not a surprise because we have the privilege to have two distinguished speakers. First one, Victoria Delgado from Leiden University Medical Center, Netherlands, and also Andreas Hangendorf from the University Hospital in Leipzig, Germany. They will discuss the important role of imaging in TAVI. They will first address the appropriate approach in aortic valve stenosis with echo, and this may be sometimes quite challenging. Then they will discuss the different echo modalities that can be used, and finally the added value of other imaging modalities. And finally, we will address the topic of the complication of TAVI and the role of imaging to evaluate these complications. Before we begin, I want to insist on the interaction with you, with the attendees. First, during the webinars, you will have to answer to some questions from our speakers, and you will have, let's say, 2 to 3 minutes to vote for the answer. You will also find on your screen on the bottom right a Q&A section, and this allows you to ask some questions to the speakers, and I will relate these questions to our speakers after the two presentations that we will have now. If we receive too many questions to be answered during the webinar, don't worry, we will address these questions with my colleagues here after the webinar, because we will put the recordings online in a few weeks, and we will also answer to all these questions during these procedures. So it's my pleasure now to introduce the first speaker. Andreas, the floor is yours.
Yeah, thank you very much, Bernard. First, my disclosures, and then I have to talk with you about some basics in echocardiography. So if we want to assess the severity of aortic valve stenosis, we have to have a systematical approach. So first we should describe the morphology of the aortic valve, and then we have to analyze the left ventricular function and also, of course, the left ventricular morphology. The target lesion in every stenosis is the orifice area, and we can measure or we can determine the orifice area by planimetry or by estimation by the continuity equation. Then we have the possibility to measure calculated parameters. These are transvalvular velocities and the pressure gradients. And then we have to look for cardiac alterations due to the valvular defect. So normally, for instance, in aortic valve stenosis, we have an increase in left ventricular end-diastolic pressure. And then we have additional investigations when we are not sure about the diagnosis, like transesophageal echo and stress echocardiography. So when we look to the guidelines, the severity is described due to the parameters jet velocity, more than 4 meters per second, mean gradient, more than 40 or 50 millimeters of mercury, aortic valve area should be less than 1 square centimeter, and the indexed valve area and the velocity ratio are different parameters. When we look for these parameters, we have, of course, to keep in mind that all these parameters, or that the velocities and the gradients are flow dependent, and therefore there are some determinants of these parameters. So the contractility of the left ventricle, the heart rate, the stroke volumes, these are the important parameters which influence these gradients. Of course, also the size of the aortic root plays an important role, and of course methodological factors. For instance, the Doppler angle or the wrong Doppler angle can influence our calculations. So also the planimetry depends on, of course, image quality, the correct sectional plane, and the correct time point of measuring in the correct sectional plane. So when we see here this example, this is of course the parasternal long axis view and short axis view of an aortic stenosis, and I think the planimetry even in this parasternal transthoracic view is well possible. We see the gradients, and normally we would say this is normal flow, high pressure gradient aortic stenosis. But is this really the only thing we can assume that we are correct? So there are some methodological issues we have to keep in mind. First, the gradients have to be well determined by the correct acoustic window, and especially the jet formation to the ventral region will be often determined at best from the suprasternal or right parasternal approach. So this is, I think, very, very important to know that we have to check all acoustic window to get the best transvalvular gradient. The next point is also when we position the sample volume in the left ventricular outflow tract using the continuity equation, we have to be sure that we position the sample volume at the correct point where we have measured the left ventricular outflow tract diameter. And from my point of view, this is best possible from the apical long axis view and not from the five-chamber view, because in the long axis view, you see exactly the point where you can position the pulsed wave Doppler sample volume where you have measured the left ventricular outflow tract. In the five-chamber view, you have an oblique view, and often this happens, what you see here in these images, if the contours in the pulse in the PW spectrum are not really well, then the quality of the Doppler spectrum is not well, and a Doppler spectrum of the LVO2 should be in this way, where you see contours and where you should be at the correct position. So this is a methodological issue which is very important. So now I will present the first clinical case, and you will get a question in the next slide. We have a 76-year-old female patient with atrial fibrillation, post-rheumatic mitral stenosis after commissurotomy and surgical annuloplasty in 2005. In addition, there is a mucoid impaction syndrome of bronchial segment 5 and an occlusion of the right bottom pulmonary vein. So here you see the parameters determined by echocardiography. If you use the continuity equation, you will get the parameter of 0.6 square centimeters. E is 0.03 centimeters, and aortic valve velocity is 3.4 meters per second, and the mitral valve gradient, mean gradient, is about 7, so moderate mitral valve stenosis, and the tricuspid regurgitation gives you a systolic pulmonary artery pressure of about 70. Now please vote according to the following question. This is a severe aortic stenosis suitable for surgery. This is a severe aortic stenosis suitable for watchful waiting, suitable for TAVI due to the multimorbidity of the patient. It's a severe aortic stenosis for conservative treatment due to the mitral valve problems, or it is a moderate aortic stenosis suitable for conservative treatment despite an aortic valve area determined by continuity equation of 0.6 square centimeters. So I think the time of voting is running, or?
Yes, indeed. We have still 30 seconds to vote.
So we know the indication. TAVI is indicated in patients with severe symptomatic AS. So the patient has symptoms. So the symptoms has to be related to the aortic stenosis, and TAVI can be performed in patients not suitable for aortic valve replacement. So please comment, Bernard.
So I think if we look at the votes, the majority of the attendees think that this is a severe aortic stenosis, well suited for TAVI due to multimorbidity.
So I'm really a little bit surprised because you need more information about this case, and I will give you this information. The patient's body heat is 140 centimeters, and the patient's body weight is only 47. TOE, and I will show you the planimetry in the next slide, is you see on the right side, and the aortic root dimension are very small, as you can see also on the right side. Please vote now again, and these are the same questions. Is the aortic stenosis suitable for surgery, watchful waiting, for TAVI, or for conservative treatment due to the mitral valve stenosis, or it is a moderate stenosis despite these dimensions measured by continuity equation. So we have a good left ventricular function. We see here the mitral valve problem. We see here in a three-dimensional echocardiography, of course it's a very small image now, it will be enlarged a little bit later, the aortic valve opening here, especially in this short axis view in a transesophageal echo. What do you think now? And I hope the time is over because...
No, we have still some time to vote, so it's 15 seconds left to vote. And I think indeed this new information is important to take into account, and will probably change a little bit the answers that we have received earlier. So the answers are following. Most of the people still persist to say that this is a severe aortic stenosis that is well suited for TAVI due to the comorbidity, but some people also change their mind and say it's a severe aortic stenosis, but suitable for watchful waiting. This is a majority of the answers.
Okay, when we have the mean gradient of nearly 3.3, it's in the range of nearly a low gradient aortic stenosis. But now you see here, if you make the planimetry of this aortic valve stenosis, it's 0.9 square centimeters. And you have to keep in mind that there can be an overestimating of the pressure gradients due to pressure recovery up to 40%, especially in patients with shortness of body. And so the consequence is that if we make the investigation in small patients, we should be aware of this problem. And I think everyone will be in line with me that a baby doesn't need a TAVI because every baby has a small aortic valve area, and I think no one would have the idea to treat a baby with a TAVI. So I think the planimetry is here the solution, and it documents aortic valve area of 0.9. And from my point of view, this patient is not a case for a TAVI procedure. So then we have to keep in mind, are there some possibilities that we have aortic valve stenosis or moderate aortic valve stenosis despite high velocity jets? The most possible reasons are methodological factors, small patients, high output stages, for instance, pregnancy or hypothyroidism, severe aortic regurgitation and pressure recovery. Pressure recovery was the last example. So when we have these questions, you don't have to answer which can be the reasons for this scenario. Too small diameter of the LVO2, so wrong measurements here, wrong position of the sample volume of the pulse wave Doppler, shortness of body, of course not large aortic root dimension, this is a wrong answer, small dimensions is the correct answer, and then aortic regurgitation and high output stages. So the other constellation is that we have low gradients, and despite low gradients we have aortic valve stenosis. And in this case, we have we have to distinguish between a fixed aortic stenosis, a paradoxical low-flow aortic stenosis, or a pseudo-aortic stenosis due to the reduced contractility of the left ventricle. And to distinguish between both entities, we normally use a low-dose W to mean stress echocardiography. And also here we can solve the problem of reduced contractility And if we increase the contractility and the aortic valve area will be enlarged due to the contractile forces, then we have the diagnosis of pseudo stenosis. So if we have a low flow, low gradient aortic valve stenosis, we will get an increase in contractility and then an increase in aortic valve area of more than 20%. We have to keep in mind that during this investigation, the gradients and the transstenotic velocities are flow dependent. Therefore, the heart rate should not increase more than 10 to 15% from the baseline heart rate. Otherwise, you can stop to increase W2 mean even at 10 or 15 microns. So this is, I think, important to solve this issue. Transesophageal echocardiography becomes more and more important to evaluate the morphology of the aortic valve and the aortic root. And I think the biplane method is very well from the resolution of the images, but you have to know the settings of your machine. The biplane method has the problem that the sectional plane can be not at the correct point. So the multidimensional analysis is much more better. You can visualize all the dimensions which are also addressed normally in CT, so the ostia of the coronary arteries, especially the right and left coronary artery ostia. I want to keep in mind that you can also visualize the ostium of the right coronary artery by the transthoracic approach, and I think you will see here also brilliant images where you can measure the dimension. Then I want
Thank you
to
very much,
switch over.
Andreas. It was a very nice and comprehensive lecture. Before we move on to the V2 Victoria lecture, I think it's important to ask some questions. We received already some questions, but you are a little bit shy, so do not hesitate to ask questions, and we will answer at the end of the presentation. Victoria, please.
Thank you very much, Bernard, for the introduction. And after this excellent presentation from Andreas, highlighting the important issues in the diagnosis of the severity of aortic stenosis, my next topic will be to cover which are the pre-procedural issues that we need to evaluate in patients who are candidates for TAVI, and particularly with the use of multi-slide CT. We have seen which are the dilemmas or which are the challenging issues in the diagnosis of severe aortic stenosis. But we know that, for example, for the diagnosis of severe aortic stenosis, multi-slide CT can also play an important role. And if we use functional multi-slide CT, we can also planimeter the aortic valve area when the aortic valve is open. We have also a much better spatial resolution to see the anatomy of the aortic valve. It's important for patients who are candidates for TAVI to know whether the aortic valve is tricuspid or bicuspid, and particularly in the bicuspid, if it's just a true bicuspid with a raphe between leaflets, or if it's a bicuspid valve with a raphe, that it can be challenging for the implantation of the percutaneous prosthesis. And it's important also to know the presence and amount of calcification in the aortic valve, and particularly how asymmetric those calcifications are, where are located those calcifications, because they have been associated with the presence of complications during the TAVI, such as, for example, paravalvular aortic regurgitation or even aortic annulus rupture. Later on, the most important issues to address for patients undergoing for TAVI is to size the aortic valve annulus. This size will give us the information on which size of prosthesis we are going to implant, and also to evaluate the procedural access by evaluating the peripheral arteries to know whether the patient can be for a transfemoral approach, a less invasive approach indeed, or if we need to perform the procedure through a transaortic approach, a transsubclavian approach, or a little bit more invasive, such a transapical approach. So these are all the issues that we will can address with multi-slide CT. And to illustrate this and to open a little bit the discussion, we will comment on this second clinical case on a 77-year-old male who had a previous history of myocardial infarction treated with percutaneous coronary intervention. Afterwards, the patient was admitted several times because of acute coronary syndrome, needing, in that case, percutaneous coronary intervention. And the last one was particularly in December last year, where 3 drug-eluting stents were implanted, and therefore the patient was kept under treatment with clopidogrel and aspirin. The patient is also known with hypertension, with diabetes mellitus, with peripheral artery disease in terms of peripheral artery of the carotid artery. The patient underwent last year for an endarterectomy. And the patient has also an important limitation that is caused by the Parkinson's disease. The patient was recently admitted with heart failure and was diagnosed with a severe aortic stenosis. And in the lab, you can see that the renal function is normal. There was a slightly elevated troponin. The EKG was showing no sign of rhythm with a narrow QRS and the QAs in the inferior wall. The patient had a very good response to treatment with diuretics. The echocardiography showed moderately reduced left ventricular ejection fraction, and the medication at discharge was furosemide once a day, metoprolol, aspirin and clopidogrel because of the previous percutaneous coronary intervention, perindopril and simvastatin. And the patient was referred for heart team discussion whether it would be for TAVI or for surgical aortic valve replacement. The logistic Euroscore was 15.9%, so it's a sort of a high risk for surgery, but not very elevated surgical risk. And we have to remember the associated comorbidities, particularly the presence of Parkinson's disease causing an important limitation of the daily life of this patient. If we take a look at the guidelines regarding the use of surgical aortic valve replacement or TAVI, you can see that TAVI is indicated in those patients with severe symptomatic aortic stenosis who have contraindications for surgical aortic valve replacement and are considered suitable for this treatment based on the heart team discussion always, and when the patient has a life expectancy of more than 1 year. In patients who have do not have contraindications for surgery but have a high risk, then we can discuss whether still, for example, a sutureless aortic valve replacement could be an option as well, and TAVI, and therefore the guidelines give a recommendation class 2A. And here it comes the first question. This patient was discussed at the heart team and was decided to perform a TAVI because of the comorbidities. And the first question to you all is, how would you use multislicity, or which other imaging technique you will use for evaluation for TAVI? Will you use a 3-dimensional transesophageal echocardiography to size the aortic annulus? Will you use multislicity to size the aortic annulus and also to evaluate the peripheral arteries and the thoracic aorta to decide the procedural access? Will you use just invasive angiography to assess the aortic annulus size and also the peripheral arteries that can give us also that information? Or instead, you will use, for example, an MRI, and you will size the aortic annulus based on MRI, and also you will give information on the function of the left ventricle and the presence of myocardial scar that you know that has been associated with prognostic implications. So please, if you can vote, and we can see the discussion of the answers.
Yeah, I think this is very important questions, and some response and answer will come very soon. So I think the majority of the attendees think that MDCT is important to size the aortic annulus and to evaluate the thoracic aorta, the iliac and femoral arteries.
I think that I agree with all of them. Indeed, depends a little bit on the expertise of the center and the imaging techniques that are available in each center. But I think that multislicity is gaining more and more people performing this procedure or this imaging technique to evaluate comprehensively patients for TAVI, and indeed any 3D imaging modality where we can have the entire volume of the aorta, and using multiplanar reformation reconstructions, we can truly assess the level of the aortic annulus, will give us much better evaluation of the size of the aortic annulus than just using the imaging technique. So in that case, depends a little bit on the expertise of the center and the availability of the imaging techniques to select 3D transesophageal echocardiography or multi-slide CT or MRI. How do we measure the aortic annulus? Basically, what we do is to align the multiplanar reformation planes to get the short axis of the aortic valve and scroll up and down to see how the bellies of the aortic cusp disappear symmetrically, and at that moment that they disappear, that is called also the hinge point, we can consider there the aortic annulus. We can have the area, we can have the perimeter, we can have maximum and minimum diameter because, as you know, the aortic annulus is not always circular, it's rather oval. And we can also derive several diameters from the perimeter or from the area. You can have several measurements, but remember that also the different prosthesis sizes will give you a range of measurements where you can set your measurement and see that all the measurements lie in one size of prosthesis. We can also see much better the anatomy of the aortic valve and also the calcification. As you can see in this case, is not that much calcified, mainly at the edges of the cusp and not so much in the aortic root. As I said, for example, we have two different prostheses right now. We have several prostheses, but in gross terminology, we can say that there are balloon expandable and self-expandable devices. For one of the initial iterations of the balloon expandable, these were the measurements of the aortic, the annulus size based on 2D, but the new iteration has also provided the aortic annulus area and also the derived diameter from the area. You can see that there is a range of diameters that sometimes they can overlap, but you have, my advice to you is always that you see several measurements that they lay on the same size of prosthesis. The same, for example, for the self-expandable core valve prosthesis. You have several dimensions and you have a range of annulus perimeter or annulus area to decide the size. Other issues that we can assess with multi-slide CT, as I said in the response, is the peripheral arteries anatomy. In this case, you can see that the femoral arteries are rather tortuous, and if I have here the mouse, are rather tortuous, but not very much calcified, as you can see in the multiplanar reformation planes, particularly at the level where the insertion of the delivery sheath will take place. And it's important also to know the thoracic aorta to see if there are other calcifications or other anomalies that we can encounter during the procedure. And if we are even planning, for example, a transapical access, we can also try to simulate what will be the entrance of the delivery sheath through the true apex of the left ventricle. These are the sizes for the two systems that we are currently using in our center. And you can see that more or less the arterial diameter should be above 6 millimeters. If it's below 7 millimeters, there are several classifications, then you have to be careful that probably you can have complications. Another important access that is also gaining more and more experience in several centers is the transaortic access. And in this case, multi-slide CT gives us very important information on the spatial relationship between the ascending aorta and the sternum. If the ascending aorta is located in the right side of the sternum, as you can see in the left panel, in this case, the surgeon may choose a mini right thoracotomy in the second intercostal space. But if the aorta is much more located in the middle, behind the sternum, or more towards the left, then you need to make sure that there is a space between the sternum and the aorta of at least 6 millimeters in order to avoid any complication when we access the aorta. And this is a table summarizing which are the procedural access that we have for the balloon expandable and for the self-expandable devices. For the balloon expandable, all the access are feasible. For the self-expandable, the transapical access is not feasible. And you can also use an algorithm of how to assess and how to decide the procedural access that you are going to choose. First of all, you assess the iliofemoral arteries, if they are suitable with a diameter above 6-7 millimeters, with no severe circumferential calcifications or severe tortuosity. You can go ahead through that access because it's in principle safe. But if there is one of these characteristics, then you have to pay attention and see if other access can be feasible, either a transapical access or direct aortic access, as we said, or a subclavian access. And all these access can be assessed with multi-slide CT. And from this, we can have another question regarding the use of multi-slide CT, and that I would like to challenge you. And the question will be if there is any other information provided by multi-slide CT that can be helpful for the procedural. And I would like your opinion whether you use this information or not. Do you think that there are no other informations? You think that it's important, for example, to measure the coronary ostia height to avoid impingement? Or do you think that, for example, the angiographic projections can be only obtained with angiography and not with multi-slide CT? Or you think that multi-slide CT is also a powerful imaging technique that gives us also additional information, extracardiac findings that may have an impact on the outcome of these patients? So please vote.
I think it's very, very nice to have such MCQs, Victoria, because it stimulates a little bit the discussion. And this will, I think, answer to a lot of questions that we already received. So
yeah,
I think that,
I'm glad.
Yeah, I think that we have now a lot of interaction, and we will receive very soon the answer of the attendees. And as we see, there is indeed a majority of attendees saying that, yes, incidental findings may have important prognostic implication that may contraindicate the procedure. So maybe you can discuss this and other possibilities that MDCT can offer.
Indeed, I agree with the audience on other aspects that we can assess with multi-slide CT. One is, for example, the height of the coronary ostia. If you are going to perform a multi-slide CT just to assess the peripheral arteries and the aortic annulus size, you can also get this information. And although it's infrequent, that the leaflets or the cusp of the aortic valve will close one of the coronary ostia, is always important to keep in mind in patients, for example, with very narrow sinus of Valsalva and very calcified leaflets. And in that case, you can prevent fatal complications such as, for example, a myocardial infarction. So this is one of the important aspects that you can have additionally. You can also set the angiographic projections, and that is something that you will have in the next slide, how we can do that. But instead of performing several angiographies to set the angiographic plane to define the ballooning of the valve, we can also get this information from multi-slide CT. And this is a landmark paper coming from the Cleveland Clinic, where they explain how to perform this analysis. In principle, the interventionalist, what we'll do is try to get the plane of the aortic annulus and play completely the opposite in cranio and right anterior oblique projection in order to get a perpendicular view completely. You can have also these projections using multi-slide CT, and you can have, for example, in the plane where there are the multi-slide CT views, you have the short axis view of the aortic valve, and then you have the orthogonal or the orthogonal planes with the sagittal plane and with the perpendicular plane. And in that case, you can align the multiplanar reformation to get which is the projection that you can use to get the alignment of the cusp and the annular plane perfectly during angiography, so that the interventionalist just needs to do one angiography in that projection, and if he's comfortable with that projection, can go ahead, saving a lot of contrast in these patients that sometimes they have also renal dysfunction. For the answer on the incidental findings, there are more and more evidence coming that indeed, the evaluation of these incidental findings are important, and we can classify these incidental findings as severe, where our decision of treatment will change. For example, whether there is a neoplasia, whether there is another complication, like, for example, a pulmonary embolism, or there are retroperitoneal problems that can give us complications during the procedure. These are issues that should be taken into consideration, because particularly one of the indications of TAVI in the guidelines is that if the patient can have a life expectancy of less than 1 year, maybe we don't need to perform the procedure and risk the patient. Instead, there are other non-severe incidental findings, like, for example, benign pulmonary nodules or pleural effusion that can be associated with heart failure. In these cases, it should be discussed with the heart team and decide how to proceed. And this article, recently published in the European Heart Journal of Cardiovascular Imaging, the authors propose a sort of flowchart on what to do when there are these incidental findings. So we need to discuss in the heart team, and if it's a non-severe incidental finding, then we can proceed with our TAVI. But if it's a severe incidental finding, then in the heart team there should be other specialists coming in to discuss which is the best approach for this patient. If eventually the severe incidental finding will not reduce the life expectancy of that patient, we could perform the procedure. But if it has an implication in the prognosis, then we need to reconsider the decision. Other imaging techniques that we can use, of course, that we can use magnetic resonance imaging. Is also a 3-dimensional imaging technique that will give us information on quantification of LV volumes and function, quantification of the aortic stenosis severity, and also the aortic annulus dimensions. And particularly for follow-up, it has been shown that for the quantification of the paravalvular aortic regurgitation seems more accurate. However, there are several limitations, like, for example, in patients with heart failure and devices that are not compatible with MRI, then we cannot perform this technique. And the use of PET-CT for pre-TAVI is not really in clinical practice right now. It's much more experimental and for evaluation of the progression of the disease, for example. But at follow-up, PET-CT can be a useful technique when we have the suspicion of endocarditis of the prosthesis. So in summary, these are the imaging techniques additional to echo that we can use in patients for selection of TAVI. Continue with the webinar. We have now to address which is the imaging technique that we will use for the peri-procedural guidance. And in this case, we can have a lot of discussion because there are more and more labs where they are performing the procedure without sedation, and they just use angiography and transthoracic echocardiography to evaluate the result. But still, there are many centers where the procedure is performed under anesthesia, and particularly when there is transaortic or transapical access. In those cases, we can perform transesophageal echocardiography and monitor the ballooning of the valve, the device positioning and deployment, the results of this TAVI in terms of hemodynamics of the valve and the presence of paravalvular regurgitation, and also monitor, importantly, the complications, one particularly, for example, the annulus rupture and the pericardial effusion. In terms of peri-procedural imaging, we can assess, first of all, which are the planes that we will use. For example, with the biplane, you can have the perpendicular views in order to see the anatomy of the aortic valve. We can also monitor the function, and we can also check whether there is mitral regurgitation or not, and if it will be a change after TAVI, because it can be a reduction, but also can be an increase if there is any complication related to the mitral valve. For the ballooning of the valve, the interventionalist with angiography will use it. But, for example, in terms of echocardiography, it can be important also to see how the annulus expand or how the sinus and the leaflets expand. And sometimes we can see that the leaflets even can close coronary ostia. So that is also an important step to monitor. In terms of positioning the device, the current devices that we have, they don't have really an echocardiographic markers where you can see if to place it a little bit higher or a little bit lower into the LVOT. So this is based on your expertise and your daily practice, how you do. But particularly it's very useful the use of perpendicular views simultaneously to see the positioning of the device. Here you can see, for example, if I can manage with the mouse, yeah. This is the central view, but on the other side, on the left, you can see that there is a much higher thickening of the device, which indicates the presence of the valve. And the deployment can be also performed with angiography, and is always performed with angiography, but again, you can see how the prosthesis is deployed and whether there is distension sometimes, or how the leaflets are pushed toward the sinus to see whether there is potential complications of coronary occlusion. One of the complications is, for example, the cardiac tamponade because of annular rupture, as you can see in this angiography. And this is a very life-threatening complication because these are very thick ventricles with very low resources to respond in pericardial effusion, and even with minimal pericardial effusion, you can have a cardiac tamponade that should be solved easily and very rapidly and send the patient for surgery. And for the rest of the results, I pass the word to Andreas to talk about the paravalvular aortic regurgitation.
Yeah, thank you, Victoria. Nice images, brilliant images.
Thank you.
I want to add for the echo imaging during the procedure that we have in nowadays really brilliant possibilities also to monitor the ballooning, for instance, as you see here in a bailout situation in a patient who is sedated and he was in a sepsis. And just for bridging to TAVI, we performed valvuloplasty of the aortic valve, and you can see here in flexi-slide mode the correct dimension in live of the ballooning and of the opening of the aortic valve. And I think this is very helpful for the sizing of the balloon. And I also want to focus, and this is also a point you have to mention in mitral valve procedures, be careful and protect you against radiation, especially as echocardiographer in front or at the head of the patient, and use all protection systems that are available. Beside the acute complications, we have also complications during follow-up, and I think there is the role of echocardiography, again, the primary role. We have the regurgitations, and also, of course, after the TAVI procedures, there are still gradients which document high ppm. Then we have also other complications like syncope. Then we have thrombosis at the TAVI devices, prostatic endocarditis, as Victoria has shown also in one slide, and of course the increase in mitral regurgitation and the decrease in left ventricular function. So just to see here an example, this is an old lady of 91 years. She had had a syncope and fall injury. And this is a typical documentation that you have still really relevant ppm. And when you see these results, then you measure aortic valve area of 0.6 after TAVI, you measure an increase E to E prime, you measure an increased systolic pulmonary artery pressure, and then you have to ask if this is possible because something was wrong with the procedure. Is the procedure okay despite a high ppm? Is the increased E to E prime due to the functional state of the aortic stenosis after TAVI, or is this due to the age or other reasons? And in this case, and you see it on this near real full volume data set on the right side below, because these are three cycles, and the middle cycle is more than 6 seconds, and this was of course the reason here of the fall injury, and sinus arrest was the problem after TAVI. So this is not a problem which can be echocardiographically documented, but it's also a problem you will find in TAVI patients. So I think this is still the problem, and also here in this patient where you see a small regurgitation and you see also a severe gradient, again, we have to perform really accurate analysis, and especially in the problem of aortic regurgitation has to be really carefully analyzed, because normally after TAVI the patient has still small ventricles, small cavities of the left ventricle, and then the regurgitant flow is much more relevant than in large ventricle in chronic aortic regurgitation. So when you see this, this is a typical patient. You have no prior documentation of the patient. You see the patient in your hospital for the first time, and then you have still a gradient, and you have aortic regurgitation, and you have also the relevant secondary alteration of the cardiac state. So then you have to perform really an accurate analysis of the stroke volumes of the left ventricle, and normally also of the right ventricle. I think if you have good images and brilliant image quality, you can make an assessment in this way. On the other side, I really also prefer to do it in MR, because this is the best check for the aortic regurgitation, if you can do it. And normally you should perform this approach, that you determine stroke volume in the right heart and the left heart, and then in this case you have only about 20% stroke volume, regurgitant volume. Other complications, as you see here, are perforations, and also here's a paravalvular leakage in this patient, and further complications here on the left side, again, floating vegetations in the TAVI procedure. And on the right side, you see a case of mistreatment with NOACs after TAVI. There was a big thrombus formation at the prosthesis, and I think these are examples, extreme examples of complications. And then I think we can conclude.
Thank you very much, to both of you, for this excellent presentation. I will make a short summary of the two presentations. First, regarding the role of echo. It's clearly the primary method for the assessment of aortic stenosis, but the diagnosis of severe aortic stenosis it depends on many factors. And you mentioned velocities and gradients are flow dependent. There are other factors that you mentioned. All patients with aortic stenosis should be evaluated by transesophageal prior to surgical or interventional treatment, especially to exclude moderate aortic stenosis due to pressure recovery and small aortic dimensions. Finally, procedural monitoring in TAVI by 3D transesophageal echo can be helpful, and follow-up investigation by echo are of course necessary to detect complications and to prevent treatment failure. Regarding the other techniques, Victoria has shown very brilliantly that in fact we can get additional information, especially anatomical information for TAVI, the accurate sizing of the aortic annulus, to guide the procedural access, to measure the height of coronary ostia relative to the aortic annulus, and also to provide the location of the calcification that, of course, are predictor of paravalvular regurgitation. Of course, we didn't mention the disadvantages that are, of course, the radiation exposure and the use of contrast, which can be an issue in patients with renal failure. So we have no time for a lot of questions. I have 2 pages of questions for you, so be prepared. I will begin with the first one. If we have some discrepancies between the annulus measured by CT and transesophageal echo, which one do you take, Victoria?
Yeah, that is indeed very good question, and it's quite frequent sometimes that if you have a good expertise on transesophageal echo, using 3D transesophageal echo, if you have a different measurement, and then the multi-slide CT gives you another measurement that makes you change the valve size, then I think that there should be discussion, checking again back how each expert measures the aortic annulus on CT and on echo, that both of them or the same person measures in the same way. And then you have to keep in mind also other factors. You have to keep in mind the size of the patient. If it's a small lady and you are doubting between a 23 and 26, and the measurements are in the range in between both, maybe take out 23. If the patient has, for example, very severe calcifications, and you think that even a larger size, knowing the nominal area when you expand that valve, can create an aortic annular rupture, then go for the smaller. So you have to integrate also other information, not only the echo and the CT, but also, for example, the presence of calcification and also the size of the patient. And then decide between both. I think the interventionalist and the imager, it should be a good communication.
We had some questions, especially for Andreas, regarding the way to assess the annulus with 3D echo. Do you have some tips to provide to our attendees? When do you measure it? At which moment of the cycle? So there are a lot of questions about the practical aspects.
This is, I think, also an important issue because the aortic annulus and the left ventricular outflow tract is a dynamic structure, and normally in the guidelines we decided to measure the annulus and the aortic root dimension during systole. And I think there is, we can assume that the enlargement is at the highest point. I think from the echo analysis, I think there was also a question about the diameter measurement of LVO2. We should change also an echo to make a planimetry of the LVO2 in the 3D data set to implement the correct LVOT into our continuity equation. And if you realize how to make a good echo image, this is an absolutely basic approach, I think. We often forget that high frequencies, scanning frequencies, produce better axial resolution. So normally you should increase the frequency of your scanner during TOE to get a better delineation and a sharper line. You can increase this by post-processing procedures like compression and persistence to get a sharper line. Then the next point is that you should acquire the 3D data set with the primary view of a short axis view, because this is the best view with also the best lateral resolution. So if you want to make the planimetry of the orifice area, for instance, as well as of the left ventricular outflow tract, acquire a data set where the primary scan plane is the short axis view. Normally you will get the best results and the best delineation. And then I think also the hinge point can be well fixed in a dynamic cardiac cycle, in a zoom function, in a 3D data set, and then you can really make a rotation in a post-processing and you will get brilliant images. So there are many tricks and tips.
Thank
but
you for
the time
this
is not
very practical aspects. You have no time to address all the tips and tricks that you can provide. There was a very small question, so very short answer. I think it's very easy to answer for you. In a patient with aortic stenosis, how do you assess the aortic stenosis practically?
Fibrillation.
In patient with atrial fibrillation.
With atrial fibrillation.
Yeah.
I think a good method just for checking the severity is a ratio, of the LVO2 velocity and the transvalvular velocity. So if this ratio is more than 1:4, you have good reason to assume that there is a severe aortic stenosis. Otherwise, you should assess the gradients if you want to use a continuous equation after comparable cycles of the ventricular filling. And this should be the best approach. I'm not a friend of making a mean value off. So it's better to use a long cardiac cycle, and the next long cardiac cycle, this would be the best because the filling is the best and the contractility would be the best. and then you should use two cardiac cycles to measure the continuity equation. And the same for planimetry. So use a cardiac cycle where the planimetry is in such a cycle, because the aortic valve will open then best. And this, of course, will be best in a three-dimensional data set, because then you can measure at the correct sectional plane at the correct time point.
Very good. Victoria, one of the first questions that we had is regarding the use of PET-CT to detect endocarditis. And my question is there any limitation to perform such an examination very shortly after the acute procedure, because you have some degree of inflammation? Which is the interval that you recommend before interpreting such a positive PET-CT after the procedure?
That's a very good question. I don't have experience with PET-CT in these patients, and I'm not aware of any large evidence on the use of PET-CT in patients with TAVI with suspicion of endocarditis so early after the implantation. But I think that inflammation can be one of the false positives that you don't know, and it should be you have to wait at least 3 months for performing. But I think that in that case, you have to follow the guidelines also, and to see which is the probability of having endocarditis, and perform transthoracic echocardiography and transesophageal echocardiography first, and continue with the medication. But I don't have that experience on PET-CT for so early suspicion of endocarditis after TAVI.
Okay, thank you. Regarding the use of cardiac magnetic resonance imaging, you mentioned briefly that it's important to assess the presence of scars in patients with probably concomitant ischemic cardiomyopathy. But we know from different publications that, in fact, we have also some degree of fibrosis related to the aortic stenosis itself. How do you measure it? Do you prefer to use cardiac magnetic resonance imaging? Is there another way to assess this fibrosis with, for example, echo?
That's also a very important question, and particularly I think for patients who are referred for TAVI, that are usually patients with a lot of comorbidities and high risk for surgery, you need to check in patients with reduced left ventricular systolic function, and particularly those with an ejection fraction below 30%, because those were the patients who were excluded from the randomized trials. And in these patients, we know that the risk is high, and maybe we don't get such a recovery of the function afterwards, because maybe the ventricle has a lot of macroscopic fibrosis because of coronary artery disease of infarction. So in those patients where the risk is so high, and the functional improvement that you can get maybe is low, it would be a good technique to perform to see how much fibrosis the ventricle has, how much macroscopic fibrosis. If you are asking about the diffuse fibrosis, the one that we can have, for example, in patients without coronary artery disease, that they have fibrosis just because of the pressure overload, there are some studies coming using the so-called T1 mapping, but there are some issues on how you measure and which values you take, and I think that are not implemented in the guidelines to decide whether the patient goes for surgery or not. And for the other imaging techniques that we can assess for fibrosis, we have, for example, on echocardiography, speckle tracking echocardiography that measures the deformation of the myocardium. So the active deformation, we can assume that the segments that they don't deform, they have fibrosis, and there have been some correlations in ischemic patients. And there are a lot of evidence coming showing the value of this technique also to stratify these patients for the treatment.
Okay, very good answer. So we have still a lot of methodological questions for you. You briefly mentioned the stroke volume as an important parameter to measure, indeed, to classify patient in low flow or not. So usually we use the definition that is provided in the guidelines. It means an indexed stroke volume less than 35 milliliter per meter square. But sometimes it's quite difficult to measure it, and quite a lot of variability related most of the time to the presence of the diameter of the left ventricular outflow tract. Are there any other new measures that we can use or to avoid such measurements, like 3D, for example? Can it be helpful in that perspective?
Yeah, I think you address to paradoxical low-flow aortic stenosis, and the problem is first to detect at least this entity. So if there is a calcification of the aortic valve, you can tell your fellows that they should use a continuity equation just to be aware that there is a problem. And if you will focus this problem, I think then you have to measure the orifice area with any method you want to use, so TOE, MR, or CT, to exclude or to fix the diagnosis of aortic stenosis. I think this is a very difficult problem, and there are, of course, some tricks. The potential of overestimating the severity is indeed the wrong measurement of the LVO2 outflow tract and the wrong methodological issues you perform. So this is, I think, main message is if there is a calcification and a small ventricle and a small or a small patient, then check it by continuity equation. If you measure reduced aortic valve area, be aware of pressure recovery, because this could be also the reason that you are wrong and that there is not aortic stenosis, and then make a 3D echo transesophageal to measure
available.
if available, yeah.
Okay. Thank you very much to both of you. It was really great to have you. Of course, we did not answer to all the questions.
We will do.
We will do, and this will be posted, of course, on the website when we'll put the recordings of this webinar in a few weeks, I think. So we will have time to prepare the answers. Let me also the opportunity to invite you to Seville, our next event, our next Congress. I think it will be a very nice venue, and that we will have fun there. And I have to thank, of course, all the attendees that were following this webinar and the huge work you have done. Congratulations, and it was a pleasure to be here with you in Nice.
Okay. Thank you very
much. Bye-bye,
much.
everybody. It was really a pleasure.
Bye-bye.
And I promise we will answer to your questions very soon. So don't be frustrated if we did not answer to all of them. I promise that you will get an answer by our two experts here present. Bye-bye again, and see you soon.